the evolving use of immunotherapy in primary and advanced endometrial cancer. And so let me just start. Yes. So the objectives of this talk is to discuss the use of immunotherapy in the management of advanced and recurrent endometrial cancer, and then understand the evolving landscape of endometrial cancer as we integrate new agents in this treatment paradigm. These are my disclosures. So when we think about endometrial cancer, the management has changed quite a bit over the past number of years. Traditionally, we used to think of endometrial cancer as two major types. One being type 1 or estrogen-associated endometrial cancer, which are patients who have a history of unopposed estrogen. They may have anovulatory cycles such that they are obese or have polycystic ovarian syndrome. Along with that, they have type 2 diabetes, hypertension, and a metabolic type of syndrome. And then the estrogen-associated endometrial cancers tend to be endometrioid histology and low-grade histology as well. As opposed to the type 2 endometrial cancers. Sorry, I'm just going to put people on mute. Yeah. The type 2 endometrial cancers are patients who are postmenopausal, older patients who are not necessarily obese, but then have the high-risk histologies. And we're talking about serous, clear cell, carcinosarcoma that portend a poor prognosis. So this was how we generally classified endometrial cancers in the past. And in terms of systemic therapy for endometrial cancer, there was typically one option. This is a bit facetious in that I say there's one option. We know that there were some systemic therapies otherwise that can be used, but mainly it's carboplatin and paclitaxel chemotherapy. But now over the past 5 years or so, the landscape has changed tremendously in that not only are there multiple issues or options for care in advanced or recurrent endometrial cancer, but then it takes a lot of, I guess, mental thought process in terms of evaluating each patient and trying to determine what would be the best treatment for each individual patient. I guess when we talk about, the change in classification of endometrial cancer, we can refer back to the Cancer Genome Atlas. This was a large study of endometrial cancers that were able to classify endometrial cancer into 4 groups based on molecular profile. And this was published in 2013. And you can see by genomic analysis, the 4 subgroups that were determined were poly or ultra-mutated classification, MSI, which is microsatellite instability. And then there's copy number low, which is traditionally like the low-grade endometrioid type. And then copy number high, which is like the traditional serous-like or poor prognosis type of tumors. And you can see based on these 4 molecular subtypes that there are different prognoses associated with them. So poly ultramutated in blue does very well, as opposed to the copy number high or serous-like endometrial cancers who have a poorer prognosis. And then in the middle here for the green and orange, those are more comparatively in the middle in terms of prognosis. Now, instead of doing genomic profiling on everybody, basically it's been found that with immunohistochemistry, you can also evaluate patients' markers and divide them into similar molecular subtypes. So the surrogate for IHC you can see listed here on the right, where MMR deficient subtypes are similar to the microsatellite instability high, and P53 abnormal on IHC is similar to TP53 mutation or the copy number high group. And so this brought out what we call the PROMIS classification. So the PROMIS classification was basically taking immunohistochemistry results and classifying the tumors very similarly to what was done in TCGA. And you can see the corresponding groups listed here. So for example, polymutated, we can't do by IHC, it would still require sequencing, but polymutated here is the best prognosis on the right. And then you can see on the left that the P53 abnormal group, or P53 abnormal IHC, was synonymous or is synonymous with the copy number high subgroup. And MMR deficient subgroup from IHC is synonymous with MSI high. And again, seeing that there's different prognoses that are associated with each of these groups. And you can see here as well by the PROMIS molecular subgroup that, again, the red or P53 abnormal does the worst, as opposed to the blue poly mutated. They have the best prognosis, and the other two are in the middle. So we now have changed our classification to these 4 subgroups and really pay attention to these as it does affect treatment. When it comes to the MMR deficient subgroup, there are, using immunotherapy for endometrial cancer goes back to these couple publications that were in 2019 and 2020. And these in Keynote 158, this was a phase 2 clinical trial looking at a number of solid tumors that were non-rectal cancer and treating them with single agent pembrolizumab. In this phase 2 study, there was 233 patients, of which 47 were endometrial cancers. And you can see that the response rate for those endometrial cancer was quite high at 57%. Then for the Garnett study, which was published in 2019, this was a phase 1/2 study looking at advanced or recurrent endometrial cancer, 290 patients, and using single agent dostarlimab. And when looking at the overall response rate divided by MMR deficient or MMR proficient, you can see that the MMR deficient group did quite well at 43.5% response rate. So this then was the basis for using single agent immunotherapy or immune checkpoint inhibitors for patients in the recurrent or metastatic endometrial cancer space. In 2022, there was question of whether we can improve the response rates to a single agent monotherapy by adding in lenvatinib, which is a tyrosine kinase inhibitor. So for this study that was published in the New England Journal in 2022, they took patients who had recurrent endometrial cancer and randomized them to either lenvatinib plus pembrolizumab or second-line chemotherapy in the recurrent endometrial cancer space. And you can see here that when looking at all patients and also the MMR proficient subgroup, you can see that was benefit of giving lenvatinib and pembrolizumab compared to second-line chemotherapy, and that was either doxorubicin or weekly paclitaxel. So this was shown in all patients and also the MMR proficient population. And this also was demonstrated with prolonged follow-up and saw that there was an overall survival benefit as well, favoring the lenvatinib and pembrolizumab arm of approximately 6 months. So now here, in terms of approvals for patients with recurrent metastatic endometrial cancer, then we have monotherapy pembrolizumab in the MMR deficient subgroup, and then for MMR proficient subgroup, tend to use pembrolizumab and lenvatinib. Of course, then the question came up about, well, if there is benefit of use of immune checkpoint inhibitors in the metastatic recurrent setting, what about bringing it earlier in the treatment paradigm with a combination of chemotherapy? We know that the combination of immune checkpoint inhibitors with chemotherapy has demonstrated clinical benefit in multiple cancers, and can we do this in endometrial cancer as well? So there were two major studies that were published in the New England Journal of Medicine in 2023. So that was only 2 years ago. And I will present both of them. This first one is using pembrolizumab in NRG GY018. And you can see here that in terms of the patient population, it was for patients who were stage 3 or 4 disease that are measurable disease on CT scan. They could not have had prior chemotherapy unless it was given in the adjuvant setting about more than 12 months prior. And patients were randomized. There were 816 patients. They were randomized to get either carboplatin and paclitaxel with placebos and placebo maintenance, or carboplatin, paclitaxel, and pembrolizumab given in combination for 6 cycles every 3 weeks, followed by pembrolizumab every 6 weeks for an additional 14 cycles. The primary endpoint for this was PFS, and you can see when they looked at the results based on the MMR status, that MMR deficient population had a substantial benefit in terms of progression-free survival with the addition of immune checkpoint inhibitor. And you can see the hazard ratio here being 0.3, meaning that there was a 70% reduced risk of progression with the addition of pembrolizumab to chemotherapy followed by pembrolizumab maintenance. And then when they looked at the MMR proficient population as well, you can see here again that there was a substantial benefit with the combination, the hazard ratio being 0.54, but still a benefit with the MMR proficient population demonstrated here. At the same time, this study was going on, also published in the New England Journal of Medicine in 2023, looking at the dostarlimab in a very similar patient population. And you can see here for this study design, again, it was for patients with stage 3 or 4 endometrial cancer. They had to have visible disease on their imaging. In this situation, they included carcinosarcomas. Carcinosarcomas is a very rare histology, which are often excluded from a number of clinical trials, but were allowed in the study. Also, patients could not have used carbotaxol before in the past unless it was more than 6 months prior as an adjuvant treatment. And again, patients were randomized in this study with to either carboplatin and paclitaxel alone with placebos, or carboplatin and paclitaxel with dostarlimab for 6 cycles every 3 weeks, followed by dostarlimab maintenance. And the maintenance therapy went up to 3 years. Again, PFS and OS were the primary endpoints. This slide only illustrates, again, the key inclusion criteria, which I have already stated. It was for patients with recurrent or primary advanced disease, the first-line setting. They had to have measurable disease. They were allowed to have carcinosarcomas in here. And basically, I point out on this slide that you can see here that the majority of patients, approximately half the patients had recurrent disease as opposed to primary stage 3 or 4 disease. And you can even see primary stage 3 disease was about 18% of the population. You can see that carcinosarcomas were included and comprised about 10% of the population. And then also that when you look at the proportions of patients with MMR deficient disease or MMR proficient disease, the division is about 75% MMR proficient and 25% MMR deficient, which goes along with the proportions out there or prevalence of MMR deficient disease. And again, here in this study, which is called the Ruby trial, you can see with the MMR deficient population, there was a tremendous benefit demonstrated with the addition of dostarlimab, followed by dostarlimab maintenance. And again, the hazard ratio was 0.28, which was a decreased risk of progression by 72%. In the overall population, when you're looking at everybody together, MMR proficient and deficient, again, demonstrating a benefit, though demonstrating a benefit of PFS. And then looking at the overall population for overall survival, again, you can see that there was a statistically significant overall survival benefit favoring dostarlimab with chemotherapy. And when you divided it into the MMR deficient population as well as the MMR proficient population, you can see, again, the hazard ratio being 0.32 for the MMR deficient population. And sorry, this is the progression-free survival, but then again, for the overall survival, there was a statistically significant reduction, though the data is not completely mature. So based on all of this, you can see that there were two very similar trials, one using pembrolizumab and one using dostarlimab. Both of the trials were for stage 3-4 disease. Both needed to have measurable disease on CT scan in order to enter the study. In terms of previous chemo, there's some differences. In GY018, you had to wait at least 12 months before entering trial if you received previous carbotaxol. Though with dostarlimab, there was a 6-month window. Carcinosarcomas were excluded from the GY018 study versus it was included in the dostarlimab study. And then in terms of the maintenance treatment, in terms of number of cycles, pembrolizumab maintenance was up to 14 cycles additional to the 6 cycles that were given with chemotherapy, versus with dostarlimab, the IO maintenance is up to 3 years. So despite the various, nuanced differences between the two studies, these were both published at the same time. And there was no question that for the MMR deficient population, and I know we're not supposed to compare trials head to head like this, but in the MMR deficient population, this is just illustrating that there was significant decrease in the risk of progression, whether you use pembrolizumab or dostarlimab. And this led to the approval of these agents in Canada for first-line treatment for advanced recurrent endometrial cancer in the MMR deficient population. When we look at the MMR proficient population, there is benefit, albeit not as wide curves as one would see with the MMR deficient population, but the use of IO in the first-line setting has also now been approved in Canada for the MMR proficient population, and there are currently patient support programs available for MMR proficient patients. Now, when we further look at the RUBY trial, the one with dostarlimab, and this was an exploratory analysis looking at the various molecular classifications that I outlined at the very start of this talk, they wanted to see the response based on the different molecular subtypes. So you can see here that representative of the population, and those that were MMR deficient comprise about 23% of the population. And you can see the various proportions illustrated here. And then when you look at the exploratory analysis of the progression-free survival by molecular subgroup, again, what is known about MMR deficient subgroup, you can see the large difference in PFS with the addition of dostarlimab. For those who are polymutated here on the left, polymutated patients do very well. And so this basically confirmed that the use of additional IO in the subgroup is probably not of benefit. Then you can see here in the P53 mutated subgroup, there seemed to be a benefit from PFS, but not so much in those who are P53 wild type or have what we call no specific molecular profile. Again, for overall survival, you can see the curves here, again demonstrating the benefit of dostarlimab in the MMR deficient subgroup and also in the p53 mutated subgroup, but it suggests here in the patients who are p53 wild type or the no specific molecular profile, that there doesn't seem to be as much benefit demonstrated in this subgroup. So if you look at it according to, you have your MMR deficient up here on the right, and then all of these other subgroups are the MMR proficient subgroups. There is variability in terms of which MMR proficient patients would benefit from IO, or there's a suggestion of this anyway, given that this is an exploratory analysis. To further muddy the waters, there was then the question of, well, we see this benefit of immunotherapy, especially with the MMR deficient patients, but also with MMR proficient. Can we make the response with MMR proficient patients even better with the addition of another agent besides checkpoint inhibitor? So in this study, this was the DUO-E trial that looked at the use of durvalumab, which is a PD-L1 inhibitor, with or without olaparib for a very similar patient population as we outlined in both GY018 and the RUBY trial. So in this particular study, there was patients with stage 3, 4 or recurrent endometrial cancer, but in this study, there were 3 groups for randomization. There was a group which received carboplatin and paclitaxel alone. There was a group that received carboplatin, paclitaxel, and durvalumab, which is the immune checkpoint inhibitor, followed by durvalumab maintenance. And then there was a group that had carboplatin, paclitaxel, durvalumab, followed by durvalumab and olaparib maintenance. So olaparib is a PARP inhibitor. And it was it's the theory of this is that olaparib being a PARP inhibitor can make the immune response to the tumor even better. And therefore, if you combine it with the immune checkpoint inhibitor, could the immune checkpoint inhibitor response be even better with a combination of the 2 agents? And if you see here the results based on MMR deficient or MMR proficient, in the MMR deficient subpopulation, you can see that there is clear benefit with the addition of durvalumab to chemotherapy compared to chemotherapy only. Here you can see the durvalumab and olaparib being, fairly similar to the durvalumab arm. So in the MMR deficient subgroup, perhaps the addition of olaparib is not that much over durvalumab alone. However, when you look at the MMR proficient subgroup, you can see here that compared to the control arm, both the durvalumab only arm versus durvalumab and olaparib arm had benefit compared to carboplatin and paclitaxel. You can see here that perhaps the addition of olaparib to durvalumab had even further enhanced the PFS benefit. However, the design of this trial was such that each of these experimental arms were comparing to the control arm. They weren't comparing to each other. So, what is the incremental benefit of olaparib on top of durvalumab? It looks like there may be benefit in the MMR proficient population, but to be frank, the trial wasn't designed in that manner. So, although again, for MMR deficient population, it seems clear that in terms of the benefit of IO, again, with the MMR proficient population, perhaps we can make it better with this combination. This study went on to look at the MMR proficient population and look at the various biomarkers in the subpopulation. And basically, this is just to illustrate that the MMR proficient population is quite heterogeneous, in which that there's a lot of overlap of the different biomarkers. The study was really trying to see, was there a particular subgroup within the MMR proficient disease population that would benefit from the combination of durvalumab and olaparib? And they really couldn't find a particular subgroup that performed better compared to the others. And therefore, it was concluded that, this benefit was seen across all subtypes. But I think this brings up a lot of questions in terms of the heterogeneity of MMR proficient population. So we know that there seems to be benefit for MMR deficient. For MMR proficient, there looks like that there's benefit as well. However, can we make that benefit better? Which patients also within the MMR proficient subgroup would benefit, whether it's P53 mutated or NSMP? And then this question came up about the fact that both Ruby and GY018, you had to have visible disease on your CT scan in order to enter the trial. Unless you were stage 4, you didn't have to have measurable disease then, but if you were stage 3 at least, you had to have measurable disease. In this particular study, they were looking at patients with endometrial cancer who had curative surgery with no residual disease. And so, you could have stage 3, 4 disease, but it had to be completely resected and not seen on CT. Or there was some examples of, particularly aggressive histologies or P53 mutation in stage 1, 2 that could enter. And basically, these patients were randomized to 2 groups. You can get carboplatin and paclitaxel plus placebo in red. So that's essentially carbotaxel alone. Or you can get carbotaxel with pembrolizumab followed by pembrolizumab maintenance. In this study, however, the maintenance treatment was for an additional 6 cycles instead of 14 cycles, and as opposed to 3 years in the dostarlimab study. So in this study, again, you can see that the MMR status was, approximately 25% MMR deficient as opposed to 75% MMR proficient. You can see that the majority of patients in the study were stage 3, 4 disease, but there was a proportion of patients, about 35%, that had early stage high risk features. And then you can see the division of endometrioid versus non-endometrioid types down at the bottom here. And when looking at this, in this study, they actually found that there was no statistically significant difference between the 2 populations. And so this was different than what was seen in the advanced disease where there was visible or measurable disease. If it was all surgically resected, there did not seem to be a difference between the 2 groups, which then ended up bringing up questions like, do you need to have visible disease for the IO to work? However, when they did do a subgroup analysis looking at MMR proficient versus MMR deficient disease, you can see here that the vast majority of patients in the study, 75%, were MMR proficient. And there, again, did not seem to be a difference between the 2 arms. But in the MMR deficient subgroup, you can see the benefit of the addition of pembrolizumab. Now, you can argue that this was a subgroup analysis. It was not powered to detect this difference. You can see that the numbers here overall or proportion was relatively small, though the hazard ratio was still quite significant at 0.3. So basically for patients who have totally surgically resected disease, for this study with the addition of pembrolizumab to carbotaxel did not show a significant difference between the 2 groups, but there may be a benefit in the MMR deficient population as the hazard ratio was still 0.3. It did comprise only 25% of the population, and therefore maybe the overall non-significant difference was driven by the MMR proficient subgroup. You can argue that, this was not the main endpoint of the study to look at the MMR deficient population, but this is what we see for patients who have surgically resected disease. So knowing now that, okay, you have MMR deficient patients who tend to do quite well in the advanced stage disease. For MMR proficient, although the studies from Ruby and GY018 showed benefit perhaps it's only when you have visible remaining disease as opposed to MMR proficient that's been completely surgically resected. And so bringing in IO earlier, it brings up the question, with the success of MMR deficient disease, should immunotherapy be given even earlier for early stage disease? And this study is actually ongoing. It's a phase 3 randomized trial looking at patients with early stage, high risk MMR deficient endometrial cancer that are stage 1 or 2, and basically randomizing them to either radiation, which is standard, or radiation and the addition of pembrolizumab. So more to come, but we'll see whether the addition of IO in earlier stage disease makes a difference. Furthermore, because of the success of MMR deficient tumors and IO, do patients with MMR deficient tumors need to be treated with chemotherapy at all? This is a study that is looking at it's a phase 3 study looking at first-line pembrolizumab versus chemotherapy for MMR deficient advanced or recurrent endometrial cancer. So I know this study has completed accrual, and we're awaiting for results and analysis of this. Similarly, the Dominica study is the similar study being done for with use of dostarlimab. So again, asking the question, do MMR deficient patients with advanced disease, do they need to be treated with chemotherapy at all? Or can one be given IO alone? So again, Dominica has, I think, almost completed accrual for this study, and we'll be eagerly waiting these results as well. And then to throw a wrench in it all, there's other therapies to consider in endometrial cancer. I've talked a lot about MMR deficiency and the use of IO and combinations thereof and when to use it. But then there has been data looking at HER2 positivity. So specifically in serous cancers of the uterus, there was a phase 2 study looking at carboplatin, Taxol, and trastuzumab for HER2 positive patients, followed by trastuzumab maintenance. And in this study, which was phase 2, it demonstrated an overall survival benefit with the use of trastuzumab and trastuzumab maintenance for HER2 positive serous cancers of the uterus of approximately 5 months. And therefore, this is something that is used for our serous cancer patients that are HER2 positive. Currently accruing is GY026, which is very similar to the phase 2 study, except it's 3 arms now, looking at carboplatin paclitaxel alone versus carboplatin paclitaxel and Herceptin Hylecta as maintenance versus carboplatin paclitaxel and Phesgo. And again, all patients in this trial have to be HER2 positive endometrial cancer, but they have not restricted it just to serous cancers. It could be any histology with HER2 positivity. And then also they have included patients with early stage disease, stage 1 or 2, as well as advanced stage disease, so stage 3 or 4. This is currently accruing as well, but could also very much change the landscape of how we treat HER2 positive endometrial cancers in the first line setting. Again, as you recall from the Ruby trial and the exploratory analysis of the molecular subgroups, and demonstrating that those who are among the MMR proficient tumors, those who are P53 wild type or no specific molecular profile may not have a benefit with immunotherapy in the first line setting. And this brings up that there has been a phase 2 study looking at oral selinexor as a maintenance treatment for, and this oral selinexor is something that is used in multiple myeloma, and it was tested in the phase 2 study in all endometrial cancers. And what they found that even though the primary endpoint showed that there was no difference whether you're using selinexor or no selinexor compared to chemotherapy, it did demonstrate that for the p53 wild type tumors in particular, there was a significant difference if you use selinexor as opposed to placebo. So this is now being evaluated in a phase 3 study, which again, if found to be beneficial, can be another possible treatment in the first line maintenance setting for advanced or recurrent endometrial cancer. So all to say that endometrial cancer management has become much more complex. There's many options to consider depending on molecular subtype. And it is important to remember that with all of these therapies and maintenance therapies, it does require prolonged treatment from the patient point of view. So, of course, that comes with side effects that come with additional treatment, which means additional visits, additional blood work. There's monitoring to be done. There's increased complexity in the coordination of care. We don't know exactly what the length of time for the maintenance therapy, what the ideal maintenance therapy time should be. If you recall, in those with non-visible disease, it suggested 6 cycles of maintenance pembrolizumab. In GY018, it suggested 14 additional cycles of pembrolizumab, as opposed to dostarlimab, it was up to 3 years. And this is given every 6 weeks. So for patients, it is quite the investment to go on these treatments and maintain their therapy. And I guess this was just to illustrate how complicated the thinking that goes around endometrial cancer has become. So for a patient with stage 3C endometrial cancer, which means that, say, there's metastasis to the pelvic nodes, so you know that there's been disease that spread from the uterus to the pelvic lymph nodes. In the past, the treatment paradigm would be carboplatin and paclitaxel plus or minus radiation treatment. And we would argue about, well, would they benefit from radiation treatment or not? And but essentially, because we knew that was metastatic disease, all patients would get carboplatin and paclitaxel. As opposed to present day thinking now, we have to think about each, I guess, each level of data that we get. So for example, for metastatic pelvic disease, are they MMR deficient or are they MMR proficient? If they're MMR deficient, then I think most people would say give carboplatin, paclitaxel, and immunotherapy followed by immunotherapy maintenance. Versus if you're MMR proficient, then is it p53 wild type or is it p53 mutated? Remembering that perhaps p53 wild type don't have as much benefit to IO in the setting. Or if it's p53 mutated, is there visible disease or has it been fully resected? For p53 mutated, if you're planning to give IO, is it only beneficial in those with visible disease, such as in Ruby or GY018, as opposed to fully resected? In the B21 data, it did not look like there was benefit. And then throw into the mix HER2 positive. Right now, we only give trastuzumab for HER2 positive serous cancers, but if future studies play out in terms of maintenance treatment for any HER2 positive endometrial cancers, that can change treatment plan as well. And then in addition to all of this, how does radiation treatment fit in to the picture? When to give it? Do we give it in the setting? That still is a matter of debate as well. So in summary, the management of endometrial cancer has changed significantly over the past 5 years. Keep in mind that both GY018 and Ruby trials were published in 2023. So it's only been 2 years, and now we're full on into the administration of immunotherapy in MMR deficient endometrial cancers. We think endometrial cancer now is based on molecular classification, which then affects your treatment strategies. The use of immunotherapy checkpoint inhibitors is now standard for MMR deficient endometrial cancer and also available for MMR proficient endometrial cancers. And questions still remain, which with regard to which MMR proficient patients benefit the most from immunotherapy or combination therapy. And further to that, as new data emerges, therapies will continue to rapidly evolve and change. It has changed so much over the past 5 years. So I think this may be a very different talk in an additional 5 years as more and more data and research emerges in endometrial cancer space. So thank you very much for listening. I hope that was helpful, and I can take any questions. I assume that there are no questions, given that there is nothing that has come up in the chat.
Oh, hi, Dr. Gien.
Yes.
Sorry, I was typing it out, but I figured, oh, you know what? I'll just ask.
Okay, sounds good.
In the MMRP setting of endometrial, with all the, I guess, treatment options available, um, what other factors, I guess, come into play in I guess, the common patient populations that would have been included in kind of all three trials?
Hmm.
Like, how do you decide? It's
Yeah.
uh,
It's very good question. I mean, you can see in the two major studies that were presented, GY018 and the Ruby trial, where one was using pembrolizumab and one was using dostarlimab, that so first of all, there was benefit for both, but there were differences in the two trials. So as of now, um, dostarlimab is very readily available with carboplatin and Taxol for the MMR deficient subgroup. Um, but in terms of the trial differences, one, you could only use dostarlimab if it was less than 6 months versus pembrolizumab, it was less than, or I mean, sorry, it had to be more than 6 months since the last chemotherapy. For pembro, it was more than 12 months. It would depend on histologic type. For example, carcinosarcomas were only included in the Ruby trial, so technically you can only use dostarlimab for that, as opposed to pembrolizumab. And then there's differences in terms of the length of treatment as well. For pembrolizumab, the total is a year and a half or so of maintenance treatment, as opposed to up to 3 years for dostarlimab. So it, we don't know if with the different agents, if there's one that's better than the other, because there's never been a head-to-head comparison. We don't suspect that there is any differences amongst the different immune checkpoint inhibitors. Um, so I guess it kind of depends on things like, the nuances of the trial, who was included in the various trials and which agent was used with that. And then also, in a way, I think it becomes down to, physicians being comfortable with the IO agents. Pembrolizumab has been around for quite some time with a lot of different solid tumors that have used it much earlier than Gyn has. Um, so there's that. But from the endometrial cancer space, dostarlimab was approved before pembrolizumab with the use with a combination of carboplatin and paclitaxel. So, when it comes down to it, some people are going to be more comfortable using dostarlimab because they've had further experience with or more length of experience with that. So I don't think I really answered your question, Ivan. It's just kind of there's a lot of
it's
different things to
it's
consider.
it's a tough one. I wasn't sure. I guess I was kind of wondering, is there any patient preferences that you've encountered or factors, when you have the discussions with the patient?
So I don't think the patient really knows the difference between each agent. I mean, I think you could look at the length of time if you're
Mhm.
going rigidly in terms of the trial criteria. With dostarlimab, it is longer maintenance therapy than one would give with pembrolizumab. That saying that, we don't know what the optimal length of maintenance treatment is. These decisions were made when the trials were designed, but they're somewhat arbitrary. So, you know, could you just stop the dostarlimab at 2 years instead of going on for 3 years? Yes, you could do that as well, but in the trial itself, it wasn't tested in that way. Um, and then, of course, otherwise, I don't think from a patient preference point of view, they really know one versus the other. Um, I guess until they start experiencing side effects, and then, but they wouldn't experience both agents at this during their disease course typically.
Thank you.
Are there any other questions? So if not, then thank you very much for everyone for attending. And of course, if you have any questions afterwards, you can always feel free to email me. People know where to reach me. So thank you very much for listening.